So welcome again to the third webinar for the clinical high risk and early psychosis learning community. I really appreciate those of you who have signed up through the Absorb system. I know that some folks had trouble navigating it, and so we're doing some problem solving to try to make it as robust as possible. But I really want to start off acknowledging the wonderful discussion that we had the last time where people were bringing up a number of really important areas such as suicidality, substance abuse, self-harm behavior, trauma, and disciplines like peer support, case management, et cetera, where people are sharing resources and really having some good conversations already. So there is a feature within Absorb where people can upload things and ask questions and share with each other. So what we're hoping to do is to push out a question every week or so that's come from the network, as well as things that come out of these discussions to really encourage us to be sharing in an ongoing and meaningful way. So thank you so much for your participation. So, of course, this webinar is hosted by the OHSU EASA Center for Excellence and the Stanford University Department of Psychiatry and Behavioral Sciences as part of the National TA Network for Children's Behavioral Health, which is operated through University of Maryland, where Tiara works, and funded by SAMHSA. So what a package. Kate, you want to introduce yourself real quickly?
Yeah, thanks, Tamara. I'm Kate Hardy. I am a clinical psychologist and clinical associate professor at the Department of Psychiatry and Behavioral Sciences at Stanford, and also the co-lead of PetNet, along with Steve Adelsheim, who is unable to join us today.
And I'm Tamara Sale. I'm the director of the EASA Center for Excellence. Unfortunately, Ryan Melton is ill today and also not able to join us, so the two of us will be carrying the conversation. So today what we want us to do is just kind of lay the groundwork for the more in-depth conversations that we're going to be continuing to have. Last time we talked a lot about kind of CHR generally, what it is, what it's not. We're going to talk a little bit today about some of the kinds of decisions that people are having to make, and we're going to spend some time focused on the international guidelines. Kate's done a really nice job of reviewing those and summarizing them for us. And then we'll have an opportunity for people to share kind of what you're up to at this point, and what you're thinking about, and continuing to share opportunities for networking and learning. So, going back to the last conversation, we talked about what do we mean by stepped care for psychosis, and so this is just kind of an attempt at making sure that we're all on the same page about what that term really means. So basically, what we're talking about is recognizing that psychotic disorders occur gradually, that they go through phases. So there's a prodromal, acute, early recovery, later recovery phase, and that we need to be able to provide rapid access to effective and tailored care for individuals who are at each of those stages of illness. Now, of course, as we talked about before, the problem with the prodromal phase is that we capture a much broader group of folks who may or may not go on to develop an acute condition or an ongoing psychotic illness. And so we have to think really differently about what we're doing in that phase, because a lot of the folks we're serving actually will never develop a psychotic illness. So the webinars that we've provided so far are available through the Absorb system, and then also they're on YouTube. So there's a link in the PowerPoint for everybody who would like to see those if you haven't already. And also, if you subscribe to the Technical Assistance TA Telegram, You'll get announcements not only about these webinars, but a whole range of interrelated learning opportunities. So again, I think a lot of the folks who are on the line have recently started programs or who are in the process of starting programs, and some have had programs going for a while and have had to kind of work their way through some of these decisions. I know for EASA, we officially incorporated clinical high risk starting in 2007 for 5 of our counties, and then we rolled it out starting in 2010. But we're actually having to go back and rethink some of these same questions, realizing that we weren't as clear going in as maybe we needed to be. So, being really clear about your purpose and goals. So for example, with with clinical high risk, the most common goal that people talk about is trying to prevent psychosis from occurring to begin with. But actually, as we start coming together around what the goals really need to be, there's a huge focus on just functioning and trying to allow people to continue to function well. And so in Oregon, we actually are much less concerned about preventing psychosis than we are about preventing trauma and supporting people's functioning. The second practice element where people are making active decisions is how do you assess for that initial diagnosis and where the person is at. I think almost everyone is using a SIPS or other tool. There's some discussion about alternative screening tools on the last call. But really understanding what is that initial assessment process that you're going to take people through, what kind of functional assessment are you going to be using, and I think we have a good opportunity at this point to share what kinds of functional assessment tools different sites are using to see if maybe we can align a little bit across those. Other areas of assessment include substance use, trauma, suicidality, et cetera. Being really clear about your eligibility criteria. This is not as easy as it seems sometimes because there's so much differential diagnosis involved. But there's a real danger in being too broad in your eligibility criteria as well as too narrow. So these are all things that we may want to discuss further. How is your program linked to First Episode and other transition age youth services? How long is your program going to last? And will that affect the eligibility for First Episode services? So that was an error that we made in our initial rollout where we didn't make a clear differentiation between the clinical high risk and the First Episode program. And since we're a 2-year program, we just started to discover that people were, that there was a lack of clarity about what happened after a person had clinical high risk for 2 years and then came back with a First Episode. Had they kind of worked their way through the program already, or did they start over? And so we've fairly recently clarified with our network that a person who comes in the clinical high-risk program, once they develop a First Episode, starts that clock all over again. But those are really, really important conversations. Also social marketing, making sure that you have enough capacity to respond to the community needs so that you don't have a waiting list, looking at how people are handed off when they're screened out to make sure that you're providing enough capacity and focus so that they get to where they need to go, ability to do outreach, particularly for First Episode. That's a little less of an issue for clinical high risk, although it's still an issue. Ability to provide intensive services where needed, partnership and transparency at all levels of decision-making, attention to language and materials. Those are all kind of core components within the programs that people are developing. Let's see. I'd like to kind of back it up a little bit. I've just been kind of going through all these different areas. And I just want to back up to the beginning question about purpose and goals. So I want to throw out there, for those of you who have a clinical high-risk program, how do you define your program's purpose and goals? And also for those of you who have developed a stepped care framework, are you willing to share that framework with others? So those are the two questions that I'm throwing out there for people. I'm going to put them in the chat box. So again, we had talked about purpose and goals that it could incorporate trying to eliminate or prevent psychosis, to prevent functioning. So does anyone have a kind of clear purpose and goal statement that they would like to share with the group?
Or Tamara, I'm curious if the goal for the participants is to create purpose and goals. And if that's the case, people could let us know that as well, because that's certainly something we could be supporting through this process potentially.
Yeah, so that's an important point. So, the other question would be, do you feel like your program has a clear purpose and goals? Yeah. Okay, so LaShondre, to delay or prevent the onset of psychosis. Yeah. So that particular goal is certainly well aligned with the research, and then minimize the duration of untreated psychosis. So hopefully if you've identified them in the clinical high-risk phase, then if they do develop psychosis, they won't go on for so long. Kate Fisher, CHR provides a continuum of care to provider outreach, education, and intervention services to youth and young adults who may be at risk for developing psychosis. So in your definition, you're really looking at access to services and making sure that people have access to a whole continuum of resources. Welcome, Marla. Beverly, our goal is early screening and diagnosis to improve outcomes. So in your particular situation, when we talk about improving outcomes, that seems a little bit more focused on those functional criteria, but also symptomatic probably as well. LaShondre, improve symptomatic and behavioral functioning. Yep, so that's pretty comprehensive, so you're trying to do it all. Enable youth and young adults to resume age-appropriate social, academic, and/or vocational activity. Great. Laura Craig, reduce prodromal symptoms and decrease impact on social skills and cognitive function. So I think you're the first person to actually mention cognition. And I think, there's kind of a theme here, which is that, as we're trying to improve those outcomes, the more specific we can be about what we're trying to intervene with, the more likely we will be to be successful. Santa Clara County's mission is to promote independence and prevent onset of mental illness in Santa Clara County youth population through early education awareness, consistent treatment, and community support. So, Linda, your goal is very system-oriented, very kind of broad in terms of the spectrum of youth that you're trying to identify, and also, focused on, both that developmental progression and the onset. So if folks are interested, what we can provide the kind of summary from the chat box of all the different definitions that people have developed, and I think it is really important to be thinking about this. As we came together a couple of years ago, talking about bringing together some of the different folks who are doing this work. Jean Addington had shared research associated with the different focus, different areas of focus, and so depending on what area of focus you're trying to get at, the research actually looks kind of different. So for example, if you're trying to prevent the onset, there's a different set of research than if you're trying to improve cognition or improve functioning. Kate, do you have any other reflections from that conversation? Any other areas of focus that you think really kind of changed the direction that the program might go?
No, I think I'll talk a little bit about it when we talk about the international guidelines, but I think it's been a real evolution in the field in terms of how we've moved from purely thinking about preventing psychosis and instead thinking about the functional disability piece. Yeah.
And I think one of the challenges that I come back to a lot in this work is that there is some tension between the very broad-based support for youth who are developing kind of a range of conditions and the more intensive support and outreach needed for people who are developing a psychotic condition specifically. We've had some, we've made some attempts to kind of integrate our early psychosis and our more kind of youth, what we call a youth hub or more generalized need. And the numbers of people are really different. So, the psychotic disorder group is much smaller, and, it's easy to lose track of them. So that's always the concern that I have is the potential for losing, not doing the outreach to the folks who are hiding in their parents' basement because you have such a large volume of people who have less intensive needs coming in. Welcome Alexandria, who actually is right in the middle of the hub program and the early psychosis program in Eugene, Oregon. So you may have some insights into that as well. Okay, so Kate, do you want to pick up the next few?
Yeah, absolutely. Thanks everyone for sending those comments. So just a quick caveat, these are Ryan's slides, so I'm just diving into them as I see them and have them in front of me. And each of these elements that we're about to talk about, we are going to spend much more time on, and we'll have dedicated webinars on assessment, for example, and some of the interventions, but this is really the stage at which we are wanting to begin to introduce some of these concepts and these core elements and to think about them as these key decision points. So obviously a core element of the clinical high-risk services is assessment, and for our clinical high-risk programs we need a CHR assessment tool. The typical assessment tools that are used within agencies is not going to be sufficient for us to be able to identify if this is somebody who we may determine to be at risk of developing psychosis. And like I say, we'll go into that in much more detail as a dedicated webinar to think through the different components of assessment, the training needs around assessment, and again, one of the things that can potentially be very different from typical interventions in the community is the need for ongoing consultation and consensus around these assessments too. We also want to be thinking about assessment in terms of risk and suicide prevention as a core component of what we're offering, and considering the strengths of the individual as they present to services as well. These assessments should be comprehensive and developmentally tailored assessments. Obviously, we're talking about a population that spans quite a broad developmental range from children and young adolescents through to young adults, and thinking about how we tailor these assessments to the needs of those different ages is really critical, as is the ability and need to include collateral within the assessment, and obviously the need to do that is even more heightened when we have a younger person with a lot of family involvement. But I would say it's still very important to do if we have a young adult who maybe has less family involvement, but still that collateral information can be very helpful. In many situations, medical exam and appropriate laboratory testing is important, so that we, excuse me, so that we can consider if there are any physiological reasons for the presenting symptoms, and then taking this information from the assessment into a specific treatment plan, which I will come back to, and I know we'll come back to repeatedly in the webinars, really fits within this staged approach and this stepped care approach in terms of determining the interventions that we provide based on the assessment and the stage of the development of the individual or the development of their presenting symptoms.
So, Kate,
Yes.
I just want to add that, there are a few areas that weren't specifically on that list, but I want to highlight that they are included, which is functioning, substance abuse, and trauma specifically.
Thanks, Tamara. Excuse me. In terms of core interventions, again, I'm kind of a bit of a broken record here, but we will be going into each of these in much more depth with individual webinars. But individual interventions, including person-centered planning and psychoeducation, and there's been a lot of conversation in the field around psychoeducation and how best to convey information around this clinical high-risk period to the young person and their supporting family or friends or whoever's around them, their structure. CBT as the primary recommended individual intervention, but also supported employment and education and peer support as part of this evolution towards recognizing the need to really address functional goals and not just symptomatic presentations. Another core intervention is family intervention, and within that, structured psychoeducation and problem solving. A couple of different models around that, and again, we'll go into that in much more detail. But as part of this stepped care approach, we should have clear targeted goals throughout, and typically, and I'll get into this in much more detail with the international guidelines as well, but we are delaying antipsychotic medication except where we are either seeing a transition to psychosis or there is a rapid progression to the psychosis threshold. And within that, the conversation and the awareness should really be about the side effects, and particularly within the adolescent and young adult population, and what impact these medications may have, both beneficial but also the potential side effects of these. Tamara, anything to add?
Yeah. Well, no, I think that's a really good starting place. Alexandria asked a question about the collateral information on the assessment. The question was, is there a specific assessment that you use to gather collateral information?
So what is typically done, and again, we'll go probably into more detail with this with the folks that are going to do the assessment webinars, but using the SIPs as an interview tool for both the young person and the collateral informant. So asking the same questions of both parties, recognizing that the collateral informant is not necessarily going to have obviously the same understanding of maybe the internal processes, but they may have noticed behavioral changes that the young person may not have been aware of. So it's really important to get that additional piece. Within that context, the SIPS is also allowing us to consider the presenting symptoms or experiences in a cultural context. So the collateral informant can help the interviewer really understand, is this young person talking about spirits, and that really fits within the culture of the family and the system, or is the collateral informant saying, no, that's not a part of our family structure, that's not something that we really embrace, and this is really a different experience for us as well. So the collateral informant is so critically important in that sense.
Yeah, and they say nowadays that to diagnose schizophrenia or a psychotic illness that you really have to have that collateral observation, because often people are not aware of some of the changes that they're experiencing. I think in the CHR group, obviously, they are more aware. But, all of the tools that are designed more for individual interviews can also be reviewed with family. And we'll throw this question out for the folks who are doing the assessment webinar coming up as well. So, okay. So, Kate, do you want me to just kind of jump into the next couple just to give your voice a little bit of a break?
Yeah, I think I've got what Ryan's got, regardless of the fact that I haven't seen him. So,
okay.
Yeah, go for it.
Okay, so this is actually stuff that Kate probably has a lot more expertise in, so we'll definitely want to add, you'll definitely want to add in. And I want to respond to Linda's question, curious what the definition of psychosis threshold is. Yeah, so that's definitely, that's a, kind of a SIPS term, right? So on the SIPS tool, there's a 5 and a 6. Right, so the 5 is the level at which you're kind of still attenuated, you still have an attenuated psychosis, and a 6, you're full-blown into psychosis. So we can come back and revisit some of these questions. At the end, we'll have some additional time for conversation, but that's a real core diagnostic issue. So thank you for bringing that up, Linda. As we get into treatment targets with folks, one thing that's really important is that in both the first episode and the clinical high-risk programs, we don't treat symptoms in a generic fashion. In other words, I've seen treatment plans where there was an actual goal that said address psychoticism, in addition to the fact that psychoticism is actually not a word. We don't do that because it's not something that you can really do. It's too broad. It's not specific enough. So for example, if a person is having auditory hallucinations and they're loud and they're mean, you might want to help them with coping in how to manage in the classroom. So you're really trying to get at, what's the actual experience that the person's having, as much in their own words as possible so that they can describe what they're experiencing and how it's affecting them. But, if you look at all the different symptoms of psychosis, we actually have a list on our website, and I think there are about 35 or 40 different categories. And so, obviously you're going to respond really differently to someone who's having loud auditory hallucinations versus somebody who is really disorganized and unable to kind of figure out how to get out of their room, and somebody who has catatonia, although hopefully you won't see too many of those in your CHR program. So, again, we've talked pretty extensively about the importance of functioning and developmental progression. So, again, it's like as you think about what you're trying to do, what is it that what's their goal? How are you going to help them move forward? Do they want to become more independent from their parents? They want to earn a little money. They want to have a girlfriend. They want to pass their classes. We're really looking again at that more granular level. And then another general area to be paying attention to is just the level of distress and anxiety that people are experiencing as a result of some of these conditions. And, again, suicidality clearly is an area that absolutely has to be addressed very directly. Often it's the distress that's the most disabling for folks, that, they're really struggling. People in the last webinar brought up stigma quite a bit, that whole kind of cycle of self-stigma that can happen around, trying so hard to do what you're supposed to be doing developmentally and struggling with it, and getting negative feedback from your environment, and then kind of turning that in on yourself. So really paying attention to the level of distress. People need really concrete skills and strategies, whether it's mindfulness or structured problem solving. Again, that's very individual. We have to really pay attention to cognition. We talk a lot about cognitive remediation, although those are very intensive and structured programs, and where you're not doing cognitive remediation, still being aware of what's happening cognitively for the individual. Are they having trouble with memory? Are they having trouble with kind of connecting those dots? And are there accommodations that you can teach them, or adaptations where you can kind of break things down and help them to figure out how to remember things, or how to get out the door, or how to interact with other people. And then, of course, in the clinical high-risk group, there's a big focus on comorbid conditions, so substance abuse, anxiety, depression, anything else you're seeing that has a real clear treatment target associated with it. Kate, what would you add or refine from what I just said?
Well, I think it's also important to just recognize the overlap of these. So obviously the attention to cognition, when we think about it, having an impact on functioning, and then our ability potentially to help a young person and their family navigate school supports around that. And I think that really speaks to the need for us to be doing this within a team structure, so that a therapist perhaps can be addressing some of the distress associated with the symptoms, but a case manager or another provider might be helping to coordinate with school resources to support any adaptations that are needed to help enable that individual to continue to function well at school. So, and I think we can often think about these treatment targets as sort of these single goals that we lay out in a treatment plan, but really there's an awful lot of integration across team members to address these.
Right. Yeah. And I think it's also really important, as we think about how is this different from, what we've done in the past, as we understand the progression of these conditions over time, cognition in particular is one of those areas where we haven't even really looked for it historically. We haven't assessed for it. We haven't provided treatment for it. But we know it drives a lot of the distress. It may actually, play a really significant interactive role with the symptoms that we observe. So I think that's probably something we'll want to really spend some time talking about. In our programs in Oregon, we've also really been focusing a lot on sensory processing and assessing for kind of underlying sensory issues. And the framework that our occupational therapists have been developing, actually takes the sensory issues as kind of underlying the cognitive issues. So, we're actually starting to develop a different framework for how we think about kind of how these things build on each other. So we're doing a lot of mindfulness, a lot of things like weighted blankets, and kind of physical kinds of things that address the sensory systems, and then that have this interplay with cognition. But again, I think these are areas of assessment that most of our programs are not as familiar with, and where we may have to bring in some additional expertise to help us build that expertise. Anything else that folks would add from the conversation so far that you think that we've either missed, or resources that you'd like to just kind of throw out there that you think might be helpful for others? And I'm just going to kind of let you guys type as we go, and we'll come back to that question. And as folks are typing, I'm just going to mention that transition, of course, is also a huge issue. So thinking about how long your program's going to last and how you make sure that you don't just drop the ball, after people have left the program. And I know there are a number of other issues that people are dealing with around sustainability, et cetera. So Andrew was asking, is neuropsychological testing ever used? And I think the answer to that is absolutely yes, with some frequency. But most teams don't have a neuropsychologist on staff. And also kind of funding for neuropsychological testing is sometimes an issue. I know Alice Medaglia has developed some material specifically for people who are not neuropsychologists to at least start to get at some of the issues. There's a document she put together called something about cognitive dysfunction. I can't remember the exact name of it, but it was produced through New York State, and I can send that out to everybody if people are interested in it. She'd be a good resource as well, I think. So Cheryl, thank you, Cheryl. I would suggest that it's important for participants to be in care with a pediatrician or primary care provider to evaluate physical health. Absolutely. That's a really, really central issue. And we did refer to kind of medical testing and lab testing, but having that ongoing relationship with someone who's paying attention to physical health needs is really critical. Okay. So thank you, Andrew and Cheryl, for sharing those really important additions. So Kate, you want to talk about international guidelines?
I will do, thank you. So the team had the person with the funny accent review and talk about the international guidelines stuff. And I'm going to talk you through these 4 different guidelines that have evolved over the last decade or so, specifically around clinical high risk. So we obviously have things from Australia, from Origin, the guidelines that have evolved or been developed in the United Kingdom and within Europe, and most recently from Canada. So, oops, sorry, I'm on the wrong screen. Here we go. So the Australian clinical guidelines are guidelines that were developed by Origin, and I don't think and wouldn't say that they've been adopted as national policy necessarily, but they are certainly very comprehensive guidelines that have been developed over a number of years, initially around early psychosis, more recently including clinical high risk or ultra high risk as it is referred to in Australia. That's the UHR acronym there. And these guidelines provide a really lovely overview of their clinical staging model and the recommendations for different types of interventions at different stages of that. So I certainly recommend looking at those. And all of these guidelines are things that I believe that we can upload to the system, so we will be able to hopefully do that later for you. So recommendations specific to UHR or CHR treatment within this Australian document is that there should be the assessment of subthreshold symptoms plus a decrease of functioning and then ongoing monitoring every 2 to 4 weeks. So really recommending that if someone's presenting with subthreshold psychotic symptoms plus the decrease in functioning, then a specialized assessment should occur. They recommend that CBT should be the preferred intervention, although also recommend that supportive counseling could be offered where CBT is not available, and that additional comorbidities should be addressed, so things like depression and anxiety. They strongly recommend not prescribing antipsychotics unless there is 1 week of frank psychotic symptoms, and that goes back to the question earlier about the psychotic threshold or the threshold of psychosis. And so here is an example of when somebody has crossed that threshold and has been crossed that threshold for at least a week, that's when the recommendation is to commence the antipsychotics. And they also recommend the consideration of omega-3 fatty acids as a supplement to this treatment.
So, Kate, can I back up just for a sec?
You may.
So for the Australian guidelines, it's interesting. I think that they, in their most recent version, they started to specify the level of evidence associated with each of the different recommendations that they were making, and quite a few of their recommendations had more of a kind of consensus level versus evidence-based practice kind of level. And it seems like because this is still an evolving field, that there are some recommendations that may start to look a little bit outdated. So I'm thinking in particular about the omega-3 recommendation. I think that there's not I haven't really heard anybody say omega-3 is a bad thing, and there was kind of an initial study that really suggested that there could be a very significant impact in terms of preventing conversion to psychosis, but then the subsequent studies haven't necessarily borne that out.
Yeah, and I see a couple of comments coming in. Cheryl's pointing out there's been many negative studies regarding omega-3 fatty acids, and certainly of the international guidelines I'm going to present, the Australian guidelines are the only ones that recommend considering omega-3 fatty acids. To answer Arlen's question, there has been some evidence, I think in a single trial that may be replicated, I forget exactly, that there was the possibility that it had a neuroprotective function. But as Cheryl points out, that has not been widely replicated, and like I say, this is the only international guideline where this is highlighted.
And I think that, again, being really clear about what you're trying to accomplish is really important, because, the negative studies, there are two different kinds of negative studies, right? There are negative studies where, no, that didn't prevent psychosis from happening, and then there are negative studies where there were adverse events or it actually had a negative impact. And so, if the goal is to not do harm, and that's one thing. If the goal is to prevent psychosis, it might not be as effective. The other thing I just wanted to point out about these guidelines was that Gene Addington's meta-analysis compared CBT with supportive counseling, and really strongly concluded that supportive counseling was not anything close to as effective as CBT. Would you agree with that, Kate?
So again, this is the only guideline of the four that I'll talk about that mentions supportive counseling at all. And I think that is probably because this is one of the few countries where there's been trials that have looked at CBT and supportive counseling compared. As you mentioned earlier, Tamara, the guidelines do, as guidelines should and often do, provide consensus and ratings of the strength of these recommendations. I have not presented those in this just for the interest of time. But when you get a hold of these guidelines, that's something to look at as well. But yeah, this is the only guideline of the four that I'll talk about where anything other than CBT is recommended as an individual therapy treatment.
Okay, great. So I just wanted to because as we talk about guidelines, it's always important to kind of recognize that they're a point in time, and they were developed in a particular way that may sometimes miss important information.
Well, absolutely, and I think what's been fascinating about reading these four guidelines side by side, I've read them sort of each as they've come out over time, but sort of sitting down and doing the review of them, we're seeing this evolution, which was really interesting. So back in 2014, the National Institute for Healthcare Excellence in the United Kingdom, NICE guidelines, um, built upon the Stafford meta-analysis that was published in 2013 to develop guidelines specific to early psychosis and clinical high risk. And in 2014, this was the first time that clinical high risk was included in these guidelines. And so I just summarized here in this table a recommendation around referral if there's a decline in social functioning and attenuated symptoms, or if it's an individual with a first-degree relative with psychosis and a decline in social functioning. That's when the recommendation occurs that there should be specialized assessment for the potential clinical high-risk period. This differs from later guidelines, again recognizing this evolution, but this is what was recommended back in 2014 by the NICE guidelines and continue to be the guidelines that are held in the UK for clinical high-risk care. Specialist assessment should be conducted by a trained specialist in clinical high-risk assessment, and that psychosocial treatments recommended approach is CBT for clinical high risk, and the addition of CBT for other presenting problems. So that's, again, speaking to the need and the necessity to address comorbidities. And it's also highlighted within here that those should be evidence-based CBT models. So if we're doing an intervention for depression or if we're doing an intervention for anxiety, it should be an evidence-based protocol for depression and for anxiety. Because they looked at the data around family interventions, there wasn't the strong, there wasn't the strong guidance to say it has to be with family intervention or not. So they kind of hedged their bets a little and said this could be with or without family intervention, but don't specify a model for that. Again, as with the Australian guidelines, that antipsychotic medication should not be provided unless there's a transition to full psychosis, so unless that threshold has been crossed. But that this monitoring and follow-up should occur for up to 3 years after treatment if a person continues to have symptoms, poor functioning, or continues to present with distress.
So that's there was a question that came up about the duration. So this starts to this is the first recommendation that we've actually seen that addresses duration.
Yeah, yeah. In a manner somewhat depressingly mirroring the rather dismal current state of affairs of Brexit in Europe, we have separate United Kingdom guidelines and European Psychiatric Association guidelines. The European Psychiatric Association guidelines were made up of experts, or were developed by experts from countries across Europe, including the United Kingdom. And we start to get into more specifics with these guidelines that I think really do begin to recognize the evolution and the progression of this field. What's also interesting about these guidelines is that these are the treatment guidelines. There are complementary guidelines that focus more specifically on assessment. And so what the recommendation is from these guidelines for clinical high risk is that we're looking to aim to prevent psychosis and the development of functional deficits. And this is the first time in these international guidelines that functional deficits are directly addressed. The assessment should occur in line with the European Psychiatric Association guidelines as well. And these are interesting because they get us into a more specific, I'm just looking it up so I've got the exact language that I want. So the specific guidelines around assessment is that there needs to be attenuated psychotic symptoms, cognitive symptoms, or transient psychosis. But unlike other guidelines that have previously occurred, they don't consider genetic risk and a first degree relative with a psychotic disorder as clinical high risk. So previous assessment guidelines have typically taken these three populations as being potentially clinical high risk and certainly warranting additional assessment. So transient psychosis, attenuated symptoms, or an individual who has a decline in functioning plus a first-degree relative with a psychotic disorder. The European Psychiatric Association guidelines are taking out that genetic risk piece and instead really focusing on attenuated symptoms, cognitive symptoms, and transient psychosis. They state psychological and pharmacological interventions may be able to prevent or at least postpone first episode psychosis. And again, these guidelines are the first ones to delineate between guidelines for adults and guidelines for children and adolescents. So in adults, a staged approach should occur with the least restrictive approach offered first, i.e. CBT, and if symptoms don't remit, progress, or move into blips, which is this brief, limited, intermittent psychotic symptoms, is transient psychosis, then begin to offer antipsychotics. So by contrast to the earlier guidelines, these are saying rather than waiting for that threshold to be crossed, if we're seeing a worsening course of symptoms, even though treatment's being provided, like CBT, that might be a time to consider the addition of antipsychotic medication. As with the other guidelines, they recommend addressing comorbidities like anxiety, depression, trauma. But they recognize that there isn't sufficient evidence to take a primary preventive approach for children and adolescents, but instead, although we would be monitoring and certainly addressing attenuated psychotic symptoms, we should be really aiming to improve functioning and addressing comorbidities in this child and adolescent population. The NICE guidelines from the UK, I should say, have separate guidelines for children and adolescents, but in many ways those mirrored the guidelines for the adult population. And so these EPA guidelines are the first ones to really directly specifically address children and adolescents as a sort of separate entity. And then most recently, the guidelines that have been developed from Canada and published in the Canadian Journal of Psychiatry by Jean Addington drew upon both the European Psychiatric Association guidelines and the NICE guidelines to come up with these 9 recommendations. And again, in this paper, you can see the consensus and the strength of each of these recommendations. But what we're saying is anyone who appears at distressed, has had a decline in functioning, and presents with transient or attenuated psychotic symptoms should be referred for a comprehensive assessment. Once again, removing this piece about genetic risk, which is interesting. Assessment should be done by a trained specialist who understands at-risk mental states, the clinical high-risk population. Similar to the NICE guidelines, offering individual CBT with or without family interventions, but that comorbidities should be addressed as well, and offering interventions to prevent the development or persistence of social, educational, and vocational problems. So again, really targeting that functional piece, and I think that has been the thing that we've seen evolve the most as this field has progressed, is the need and the recognition to really identify and target functioning in this population. Both psychological and pharmacological interventions can prevent a first episode of psychosis, but the above treatment should be monitored by somebody who is expert in this field. And they present specific guidelines here in adults who are at clinical high risk for psychosis, taking the staged intervention that we saw in the EPA guidelines of the least restrictive treatment approaches, such as CBT as first choice. But if we see a continued progression despite that treatment, then to consider in adults a low-dose second-generation antipsychotic. So again, not needing that threshold for transition to psychosis to start the antipsychotic, but rather a worsening course of symptoms despite treatment. After treatments, if symptoms, poor functioning, or distress continue to monitor regularly for up to 3 years using structured and validated assessment tools. And then I just went ahead, and this is a very kind of not particularly comprehensive, just thrown together table, but just a way of sort of summarizing partly that evolution, but also these kind of main core components of clinical high risk as we've talked about them, the assessment, the psychotherapy, commencing antipsychotics, functioning, and specifically looking at children and adolescents. And this table summarizes each of those guidelines, with obviously the Canadian ones, like I said, being sort of an amalgamation and drawing upon both those from the UK and those from Europe. I'm curious if there's any... Go on, sorry, Tamara.
I'm just curious. The thing that surprises me in reviewing this is the lack of focus on family intervention. Because I know in Jean Addington's most recent network meta-analysis that she did, that was one of the things that she concluded had really strong evidence.
Mm-hmm.
What are your thoughts about that? Why do you think that that's not included in the guidelines?
That is a great question. I do not know the answer to that. I mean, the best we've got is this offer it with or without family intervention. I can only imagine... Actually, no, I'm not even going to hedge a bet as to why it's not really being included in there.
Yeah, it just seems really surprising because there was some really strong evidence,
mm-hmm.
and it might be that the evidence was more around specific interventions, so it wasn't generalizable.
Mm-hmm.
But I'd be curious what Jean might say about that for Canada.
Yeah, that would be interesting.
Yeah. Are there other things that people find surprising or confusing? Yeah, I think what this reflects is that there is some consensus internationally around specific things, but also that there are, like Kate was saying, it's really this is a field that's under development, right? So it's we can rely on the science up to a certain point, and then we have to kind of try to figure it out. So Kristen was saying, I wonder if that's because, in terms of the family piece, that's because the evidence for family interventions has yet to be replicated in CHR. I mean, it's definitely a big piece around the number of studies and the robustness of the interventions. So the same thing is true with cognitive interventions and mm-hmm. interventions around functioning, that there just haven't been enough studies to have a really clear guideline. So
yeah, and certainly there has been very clearly focused CBT studies, and again, we'll go into that in much more detail when we get into the CBTP webinar, but there's certainly been a number of focused CBT for clinical high-risk studies, randomized controlled trials that have occurred internationally. I can imagine we'll be talking about this in another couple of years, different guidelines, and with seeing, again, a progression, and that's certainly what this field is very much about.
Right. Yeah, and there are other things that in the last webinar people identified as being really core that are not listed in any of these, like peer support, for example, mm-hmm. or case management. And so I think that we shouldn't assume that because it's not in the guidelines that it's not really important. And that's one of the roles of this this learning community, is to try to kind of gather up where those loose ends are and to see if there is research that we can share, and hopefully at some point we'll have our own national guidelines. Alexandria, yeah, the vocational and education specialist has really been big in our program. Yeah, absolutely. Right. And I think, in terms of functioning, the European and Canadian guidelines that say interventions targeting functional decline certainly should include vocational function.
Yeah, and that was a big shift in these guidelines to really take it towards, I think there was a misnomer in the field that the focus on clinical high risk should be on the symptoms and should be on preventing the transition, and that, as we've talked about already, has just evolved into something that has much more been about how do we support people functioning, and really the transition is somewhat secondary, although that is the primary outcome that we report in papers.
Yeah. Well, and I also think it reflects the difference between a field that has been driven historically by research to the shift that's happening into the community. Because I know when we started doing it in the community, honestly, the transition to psychosis was interesting, but not all that important to us. You know, I mean, basically the reason we got into clinical high risk was that we had so many people being hospitalized and they were experiencing so much trauma. And also they had already developed disability before they had their first episode. You know, so we were trying to address the disability and the trauma, you know, and it had nothing to do with trying to prevent psychosis,
Right.
honestly. Yeah, we were pretty skeptical about that, honestly, whether that we would be able to do that. But
And I'm sure, as you have seen as well, Tamara, I've seen individuals who've made the transition to psychosis from clinical high risk, but been supported by a team, and it's been a soft landing, if you like, and the person's continued to function relatively well, and then progressed and improved through that process, compared to somebody with clinical high risk symptoms who hasn't made that transition but has continued to function poorly despite not making the transition. And so we can't just make that our be-all and end-all of our outcomes.
Right, right. In fact, in the EDIP study, you know, the early detection and prevention, early detection and intervention for the prevention of psychosis program, which was thank you, 6-site national study that predated RAISE, and it was led by Bill McFarlane and the Peer folks, and Oregon was one of the sites, along with Michigan, New Mexico, and UC Davis in California, and New York, Barbara Kornblatt's group. One of the really interesting conclusions was that the first episode people actually did better. So we had folks who were up to 30 days of first episode, and they started off worse and they ended up better than the folks who just stayed in the clinical high risk.
Yeah.
So it's clearly not all about the symptoms.
So maybe we want to take a couple of seconds just to ask people this question and to give us their insights of what they've learned so far, and in this webinar and the prior 2 webinars that you are thinking of applying to your agency or to the work that you're doing currently.
And then we'll still have time to, you know, for questions and answers and kind of sharing thoughts about where we want to go next. So, Kate, are we losing you?
You will be in just a second, yes.
Okay, all right. So
thank you for that, yes.
Yeah, I'll keep the conversation going.
Thanks. Okay, so I'm going to step out to see a client, everybody, but thank you very much for your contributions, and I look forward to seeing you next month.
Okay, great. And thank you, Kate, so much.
Not at all.
We're online till 11:30. If there's anyone who has to leave early, if you can just be sure to do the evaluation, that'd be great. So Candy, we'd like to focus on functioning, absolutely. So again, thinking about your purpose and goals. Arlen Hatch, really ensure families involved and consider best social support networks for those without supportive or available families. Yeah, and you know, in the first episode work, there's lots of research that supports the idea of the social support network and the families being a major influencer on outcomes. Andrew, attention to cognition and cognitive remediation is helpful, absolutely. We've got the evaluation link in there already, like the focus on functioning. Yeah, so I think you know, maybe one of the biggest takeaways from the conversation so far is really the importance of clarifying the kind of functioning, you know, that we really want to help people function, and in fact, you can have some pretty significant psychotic symptoms and still function well. And if you're functioning well, maybe it doesn't matter as much. And I think that also leads to kind of a general question about tools that people are using for functioning. I'm wondering if anybody on the line could share what tools are you currently using to measure functioning that you like? I think that's an area where we could really collaborate. So Michelle said the GFSR, so Global Functioning, Social, and Role. So that was the one that was developed. Was that developed by Rachel Lowy, or was that Tara Needham? Sorry, guys, I should know that. But it's a very simple kind of alternative that gets at social and role functioning separately. And I think that the thing that's significant about that is that a lot of the measures combine symptom and functioning, and they combine kind of social and role. And that this particular tool differentiates in a way that allows you to target your interventions more explicitly. So Michelle, the GAF, so I think probably most people are familiar with that. The DLA, Kim, I'd be curious what you think about that one. And let's see, Cheryl, agree with the GFSR developed by Kornblatt Lowy author. Okay, thank you very much. Great.
Okay, so for those of you who have not done it yet, please go ahead and join PEPNet. You can either do that by doing a search for PEPNet and joining through Stanford's site, or you can access it directly from the Learning Community software. And we're hoping that you will share with us any practices or models that you think would be a good case study, or any specific scenarios or questions that you would like feedback on. And as a reminder, these webinars occur every month on Thursdays from 10 to 11:30 Pacific, 1 to 2:30 Eastern. The next one will be focused on the voices of young adults and families. So we're looking forward to that one. And the following webinar will be focused on social marketing. Here's the link, and you can download the PowerPoint to access that. And we'll look forward to talking to you soon. So again, really encourage you to go to the learning management system where everything is being uploaded, and all the practice guidelines that Kate talked about will be there, and there will be an opportunity for everybody to continue the conversation. And thanks again to SAMHSA, and appreciate your evaluations. Look forward to talking to you soon.